what we saw in chordoma patients is that clearly not every chordoma is the same. They don't behave the same. They don't behave the same initially, and they don't behave the same sometimes after certain treatments. In addition, it was very unclear, which patients might need certain treatments like radiation.
And there were obvious tumor markers that have been investigated in other kinds of tumors that have been vaguely studied in chordoma, but had not been studied in the context of the extent of resection and whether patients had received radiation or not. The hypothesis was whether specific genetic markers were actually relevant to how the patients did with clinical outcomes. And secondly, whether these markers could actually help the team, the physician and the patient, decide how to proceed after, for example, a surgery. Would a patient require radiation? Would they just need to be observed? In summary, this is the combination of two tests, which are both based on fluorescent in situ hybridization, which is, in other words, a test that looks at losses or rearrangements of small stretches of DNA on the chromosomes. And by looking at these small stretches, we can infer that specific genes are affected. For example, the two specific stretches that we found to be more important was what we call 9p21, and the other one, well, it's called 1p36. So based on the percentage of cells in the tumor that carried one or the other or both of these abnormalities, we categorize the patients in three categories: a low risk, an intermediate risk, and a high risk. And the importance and the simplicity of this is by testing these two markers, which is a relatively simple thing to do, this potentially can predict a wide variety of tumor behavior. What we were able to derive was that specific patients, and only if they had a complete resection, they were either in the best category or even in the intermediate category, potentially withholding radiation may be an option for these patients if they had a complete resection.
What's important is that patients get a very complete removal of the tumor. And so the amount of tumor removal matters in this situation. So simply avoiding radiation without getting a complete tumor removal is not necessarily a great idea. And it's important that people get care at a chordoma specialist. Chordoma is a very rare disease, and there are certainly a handful of us scattered throughout the country, and that's been one of the important messages always from the Chordoma Foundation, is that people get care at a specialized center. At least most university centers and most cancer centers would have a pathology lab, and the pathology lab are the ones who look at the tumor anyway, who can run these kinds of tests. And they can, of course, always contact us. We're always very willing, we don't want to help all of our chordoma patients wherever they are get the best care that they can. And if we can help their lab get this information and even share it with us, we're happy to try to tell them where we think their tumor might fall. I think we're really starting to understand that chordoma patients are all very different, and we need to study that better to know how to treat each patient differently.